What's up? I'm Dr. Nick, podiatrist, foot and ankle surgeon, and nationally known for minimally invasive bunion surgery. In this video, I'm going to demonstrate how we perform the Arthrex Minimally Invasive Bunion Surgery. And it's designed for surgeons that are new to this technique, or you've traveled to Arthrex and you've been trained in it, but you're still not quite sure that you're ready to do this procedure. I'm going to answer all of your questions. I'll give you some tips and tricks and some pearls on how to do this procedure. I'm walking you through step by step on a surgery that was performed on a real patient that had given us permission to do this as I was consulting and teaching another surgeon. If you have any questions, please drop them in the comment section below. I'd love to answer them and help get you through this new technique that's making patients' lives so much better. It's a fast recovery. The correction is amazing. We can correct even severe bunion deformities with large ion angles. Let's get started. I hope you enjoy this video. Beaver blade carry. And I'm just taking snapshots. I never go live because you don't want to waste C-arm. So they teach it to go just proximal to the sesamoids. Okay. I do the opposite. I go a little more proximal. So I just make a stab incision. I don't do any periosteal elevation. I'm trying to get it right at that apex of where the curve is. Okay. I go a little bit more proximal because the problem is if you're under the sesamoids and you're in a danger zone. Like you're cutting bread, okay. They want us to tell you to rotate from a pivotal point of where it's inserted. Okay. Can you give Dr. Kanagar some saline? Can you just drop a little bit on the... Absolutely. Thank you. So they want us to tell you to pivot around the entry point of where the burr is entering the bone. So I got all the way through. I'll pull out just to take a shot to make sure. Okay. So good, I'm all the way through. Now this is where the shifter device comes in that we were talking about. Can I have the bigger one? There's a bigger head. There's two sizes to this. I use the bigger one just because of the physics of the pressure. Okay. If it's smaller, it'll create more damage. So I use the larger one because this is that part that's supposed to go through an incision. Okay. But I'm just gonna go right against the skin. Okay. The stem goes into the shaft.
And that abuts the med head?
That abuts the med head. Okay. Now, this is a little bit tricky because the design of this doesn't allow you to go in as far as possible.
Okay. So you're not putting this part in the measure?
It is, yeah, I missed it. Now I'm in.
Okay, got it. Okay.
We used to use a hemostat to go in and push it over. So what I'm trying to do now is I'm trying to get my sesamoids lined up. We'll do both. So there, I like where my sesamoids are. Okay. The wire that's gonna, Jake, can you point and show him where the wire is gonna exit and show him how that works?
So the wire comes through this canal like here, and right in the middle it's gonna shoot that way. Wherever this wire ends up is a trajectory of where your most proximal wire is gonna come and meet it. So
take the wire, Carrie.
Wherever this wire is gonna end there in the med.
Short one.
That's where the proximal screw is.
Short one, with the gun, sorry.
And are we putting any lateral pressure on that med head to keep it where it's at? Or when you put your guide wire in there, are you just shooting it across?
I'm just shooting it, yeah.
You're not using any lateral compression to kind of keep
just
where you want it to be?
Where the threads are, you can thread it and push it over. What some other surgeons do too is they'll make an incision here and put this piece against the side of that head, and you can push it over. He does a lot of his own he does a little twisting and cranking as well with his hand. Because that way you can, with the strands where it's cut, now you can twist the head and you can
So, I don't like where my wire is.
Does it need to be
but yes, okay. But I'm gonna keep it there because I want the screw to go more central. If I take it over too far lateral.
Where do you want that distal end of the screw to end?
About right up there.
Right.
But
right
like more is distal in the head as possible and still grabbing bone.
So it's gonna come to like right about.
Yeah,
okay. But
I'm gonna miss it with where I'm at now, and the reason is because I can't get, this goes in the whole way, the wire's gonna be too proximal. If I pull it out, it's gonna slip out. So I'm gonna split the difference. This is gonna shift us over. So once the
hybrid version, okay?
The wire's in, I'll start shifting. So see, there's a little bit of space there.
Yeah.
But I like our correction, so we'll probably...
And that wire looks like it became...
It
kind of, yeah.
Yeah, it's bending a little bit.
Okay.
We're gonna probably fix that once we get our wires in.
Okay.
Darn
So when
it.
you use that shifting device, you're opening up the IM angle here, so it pulls it this way and kind of puts it at an angle now.
Okay. And what are you using this for when you're twisting?
Pushing it away from the metatarsal and bringing it back. So I'm trying to bring it back a hair. There, now I got it, now we're
That's the
touching.
wire you're moving.
Yes, it's the pusher and the, no, just the pusher.
Yeah, so this end here pushes that over, and that's what threads.
Now this is that triangulation device,
Okay.
which is to get those wires in for the screw. This is
Got it.
only, we've already done our correction. We can do some minor adjustments
Okay.
once the wires go in. This clamp I'm turning now has to tighten down on that laser line. If it doesn't, it won't triangulate.
Okay.
There's a little black laser line, the farthest one towards the end of it. So that's gonna clamp down there. Now this is gonna move. We're trying to get this as proximal as possible so that when our guides go in, the dorsal aspect of the Met, I think I like it right there. These are beveled at the tips to allow, and this is only for wire placement. And then they come, as soon as I get these wires in, this whole thing comes off. I'm trying to get this first wire to start row right at the base.
Yeah. That's where he wants the wire to start coming back. Okay.
So it's right over here and it's going to
Okay, got it.
because ideally it's going to connect.
Okay,
to your
got
wire
it.
here.
Okay.
He's going to reposition that one so that'll change.
Okay.
So I'm trying to go as proximal as possible and the Met. So I'm gonna go a little more proximal because usually what happens is that's gonna skive and I'll miss the base a little bit. So I'm gonna try and get it just a hair more proximal. I like that. And I start this by hand first.
So let me ask you, so
Mm-hmm.
you're putting your wire in, right? Say you're missing where you want it to end up. Are you able to bring it back out and
Yeah.
redirect it
Yep.
multiple times?
Can you come back towards me a little bit? Yeah. Let's see. Good. So now I'm hitting that. With your proximal wire, you always have to hit that far or lateral cortex because you want to have 2 points of fixation in that first wire or screw. So see how I cheated and I'm missing the most lateral aspect of the med head, but I knew that wire was going to end there and I wanted it to go in that direction. Okay, we got one in. The guide is set up to put a second, the trajectory guide is set up to put a second one of these guide wire canisters in or whatever you want to call them. I just take it out and put it right next to it because it gives me a little more control of where I can place that second one because I don't like them to be too far apart. So I like that. I'll take another wire.
So where's our second wire wanting to end up? Okay. Kind of splitting where that guide wire is.
Yeah, try to,
Yeah, I try to, as most central in a head as possible or medial to that. I don't want it to be any more lateral because I already have one lateral. The lateral one's to prevent rotation. This one's just more for stability. I like that.
So do you take a lateral to see how much everything?
I'm going to leave it there. You want me to pull? So that's a good point. So Eric was saying I exited the medullary canal. I think we're okay, but what I could do is...
So here's my question to you. Should that met head be touching that metatarsal?
It should be, yeah. We're going to push it over once. So if... It's still finding that same trajectory. But sometimes you can get both of these in that far cortex. So like, I'm missing it. I'm just going to go into the head because I liked where I was. Okay, the guide has a slot in it to see if you can do a lateral, but I don't really like it because sometimes you can't really tell. There you can tell. I'm in the head. Yeah, but what I'm going to do is take it off because I'm worried about the pressure of that pusher on the head. So this whole thing's going to come off, and it's served its purpose just to get those wires in. And this isn't even needed anymore because the wires are holding the head where they're at. So this will all come off. I'll leave this in because I can still get some rotational correction. So we're center enough that the screws weren't. That one is a little bit planar, but I'm okay with it. Yeah. So if I push on the capital fragment, maybe they'll move into the wire a little bit. I don't know. And I don't like where my sesamoids are, so we may correct those. So see, I still have some play where I can correct it as I'm putting that screw in. And yeah, there's a space. So
let me ask you this, do you need to bring the head up a little and bring it over a little so it's touching, or?
Right now I just pushed on it.
Okay.
So let's do this. Let's take the proximal one out. So if we take that one out, we've got a rotational point on that other one.
Okay.
And I might be able to push it in a little more. I kind of like where the sesamoids are going, but I don't like the position of the head. Okay, will you drive that other wire in, Dr. Kanikar? The one that's the proximal one? So what I'm doing is I'm forcing the head in a different position. So before you drive it, let's look at it.
Okay.
So see, I'm rotating my sesamoids, I'm bending that other pin, and we're gonna, yeah, now you just drive that one and that's gonna hold it. Perfect.
Good.
Now back that other one up and let it bend straight and put it back in.
So bring it out.
Yep, just bring it out of the head. I don't think it's grabbing. There you go, I felt it. A little more. Good. Now, see if you can drive it into the head again. You might find a new hole. Back.
Yeah.
I'm gonna push the wire and see if it moves it. That's kind of where I'd want them. So we might get a little more once we drill it.
Okay.
So we drill one at a time. I'm gonna make a little stab incision to open this up. And if you drill them both at the same time, it becomes a little wobbly. So usually we just do one at a time.
He took the other segment off that device and noticed.
Oh yeah, there's two parts to this. The other one is wider and it fits into the trajectory guide. I'm gonna push a little more to get all the way up against that flare. And we are at a 52. I would go true to that because we have space. So we'll put a 52 in proximal. Let's do a 42 distal.
Okay, what did it measure at?
Almost a 44.
Okay, yeah, I agree.
So I backed a little bit off because it was close to 44, so we're gonna go
Same
40.
rule, kind of subtract 2 millimeters?
You don't really have to because they're beveled,
Okay.
but I'm looking at this being a little close to that joint space, and I know I have enough of it in the head, so then I advance these so that they don't pop out when I'm drilling. Some people will say don't advance through the cartilage. Others say it doesn't matter, so there's really been no definite answer to that.
Got it.
I just go through so that they're not
Okay.
sticking out. And I kind of like my sesamoids there. Let's see if, yeah, that's not bad. I think we fixed them. That looks good. So we're gonna drill this proximal one first. When we did the compression screws, we always went proximal first. I don't know if it matters as much. There's times I'll do the distal wire first.
And you're drilling all the way across?
I'm going all the way across into the met head.
Okay.
I'm getting that far cortex. And if you notice, I've got my left hand. I'm always constantly applying pressure and twisting that because I still feel like I can get a little bit more. So I drilled her all the way to the end. Sometimes I won't go as far because these screws are self-drilling, self-tapping. So it got stuck in there. Can you get that out, Carrie? That's why we usually drive it and it's still.
That's really gross.
What?
Drills being clogged with bone.
They're throwing out every time.
Okay, but I'm gonna double check on a lateral.
I'm sure if you're doing them multiple times, you're
You're creating more holes,
Yeah.
exactly.
Lights.
Yeah, so always check a lateral when your wire comes out. So these screws are beveled and then there's a laser line on the driver.
Okay. Right there.
Yeah.
Okay.
And it doesn't matter, as long as you line it up,
Okay.
it just gives you a reference point so you know, hey, when I see that laser line,
Okay.
it's in a position where it's going to be flush with our metatarsal. So there's my laser line. I'm pretty close. I'm going to do a couple more turns. Yeah, I like that. So we'll drill the other one. See how that's flush. We can even probably go one more turn with
I would
it.
say how much of the threads you want to get in that head?
As far as I can without hitting the joint.
Got it. So you could have gone a little longer.
I could have gone a little long. Yeah, definitely could have. But then the worry is, well, if I get it into the joint,
Right.
or if it's going plantar and it hits,
Got it.
comes out and hits the sesamoids. Okay, so I'm hitting that wire. I'm gonna back this out. I'm not gonna drill any further because they're self-drilling, self-tapping. I'm gonna pull this wire out, Carrie. No, it just came right out. I don't need the driver. What I don't like about, I'm a little close to that medial eminence, but it's not gonna matter. I mean, there's enough. So you don't wanna drive it into the head medially. You're just,
Yeah, all of it. No, there's a saline now.
same thing, I'm lining up with my bevel. Sometimes those get hung up on the skin. I just go in, it'll mark the skin a little bit, but it never creates a problem. Okay, so we can go a little further. So my bevel's not lined up, but I can see the laser line. Good, I like that. Okay, we'll take the wires out, Carrie. See how, if you're not proximal with your drapes, these all get, and then that adds time to your case because you're struggling with the darn drapes trying to get your hand back here. That's why we say to make sure you go with the proximal calf tourniquet. All right. Good. So I like that. Then I always come back and look. We're gonna do a Aiken because she's still touching a little bit, and we might be able to get the toe a little bit straighter. So the Aiken, there's a couple different ways to start with your wire. Can I just have the wire first, Carrie, by hand? I used to put my wire in this way.
Okay.
And then we started doing it this way through this hole. You can sometimes get it started through the hole so you're not making another stab incision. And what I'm trying to do is get it into the base of the proximal phalanx, and it would go in a manner perpendicular to where my cut's going to go. So kind of the wire driver, Carrie. We're gonna try it. If it works, it does. If not, we'll do it in a different plane. So I have it up against the base of the proximal phalanx. I drove it. So I don't like that orientation. I'm gonna recorrect.
Are you always doing an Aiken with your MIF?
99% of the time.
Yes. No issues with that.
So see, I'm in the center part, and I'm just putting this in prior to making my cut because it's easier to do because I have a solid bone. So I'm gonna back it out halfway. Good, now I've got space to make my cut. Now I'm gonna take the beaver blade and go as far distally on that proximal phalanx as possible. I can advance the burr proximally to start a cut, but once I'm in that hole, it's hard to come back distally on it. So I'm usually going oblique when I make my Aikens as opposed to perpendicular.
Okay.
It all depends on what type of deformity I have. So I went in, I found the lateral cortex. I don't like that. I'm a little bit too far proximal, so I still have the ability to move my burr. There, I like that. So I'm oblique. My burr is touching the tip of the lateral phalanx, and that's going to be my hinge point. I'm going to burr and cut dorsal, and then cut plantar. And I usually do this with one swoop because it's just mentally.
You want the lateral cortical hinge intact.
Yep. See, and I might have left too much of it. We're going to try and close it down. Let's see if it closes. And if it cracks, that's good. That's okay. Yeah. See, it's starting to close. Yeah, I got it to close. So I'm going to hold that closed with my hand and advance this wire. And I'm not going to measure this wire with the measuring guide. We're going to measure it by superimposing. So I'm just going to hold correction and advance that wire all the way through. See, it's coming out by my finger. And that got us a little bit straighter. We'll superimpose. These are usually like 24 to 28, right, Jake? Am I?
Yeah, that's 28 there. Might be a little long, but I don't know, actually. That might be a little short.
Short. But we're getting close to the joint. If I close this down a little bit, I'm going the wrong. Might be short, huh? But I'm getting close to the joint where that wire is. This is a 28?
Yeah. Do you want to go with the 30?
Let's do a 30, Carrie. I'm gonna just drill. I don't always drill the whole way through. Can I have the drill? I have it advanced already. I usually just start the drill in this part to get the screw started, because her bone is, it's not extremely hard. If it's a hard bone, I'll go the whole way through. If it's softer, I'll just get it started.
Okay.
Yeah, see, it went in nice. It went in easy, so.
30.
30. I'm holding correction as I'm putting this in. So the one part of this technique that I didn't show in this video is how we remove the medial cortical margin of that first metatarsal. And typically what I'll do is use the Arthrex burr to shave down the external portion of this bone. And I'll start from dorsal medial. I'll just keep gradually taking away that medial margin of bone until I get enough of that taken away so that I have a flush margin that's even with my toe. And I'll do this by inserting the burr into the proximal most screw margin, as it tends to line up evenly when we resect the metatarsal bone away. It makes a nice flush margin. You can also resect a portion of that bone and impact it into the medullary canal of the metatarsal, although I would caution you in doing this because sometimes it can float out and calcify down against the metatarsal and become a prominent margin for the patient. So unless you're quite comfortable in doing this and you make sure you've impacted the bone immediately, I would encourage you to try shaving away the bump first with the burr. And I usually drop it back to about 3,000 RPMs. But if it's a harder bone, we'll keep it around 6,000 RPMs.